Well, welcome everyone to the EKG case for the week of April 8th, 2012. We're going to continue on with the theme of Wellens that we started a couple of weeks ago. And so 2 weeks ago, we talked about Wellens syndrome or Wellens sign. And then last week, we talked about a mimic. And this week, we're going to talk about another mimic of Wellens. This is another one that's commonly mistaken for Wellens. And it's not necessarily well described in the literature in terms of formal studies, but it's well reported in terms of textbooks and the journal articles and just teaching courses, teaching cases that people talk about with regards to this particular abnormality. Let's take, for example, this 49-year-old man with vomiting and diarrhea for 3 days, and here's the 12-lead EKG, and hopefully what's jumping out at everybody is obviously these abnormal T waves in his mid-precordial leads, especially here in V2 and V3. It extends out to his right precordial lead V1 as well. But, looking over the past couple of weeks of cases, we've talked about the importance of these biphasic T waves in the mid-precordial leads, especially V2, V3, V4 also. In this case, V4 looks okay. But when you see those biphasic T waves in the mid-precordial leads, what you're supposed to worry about is Wellens, which is a highly specific finding which predicts a critical stenosis in the proximal LAD. But the question is this Wellens? Well, it's probably not, since I already told you that we're going to talk about a mimic this week. And what this particular T-wave abnormality is actually turns out to be severe hypokalemia. Severe hypokalemia, well, let's talk about hypokalemia just in general. When patients develop hypokalemia, there's a few things that happen. They start developing U waves, which can merge on to the T wave, and if you don't notice that there's a T-U fusion, you may end up thinking simply that there's a prolonged QT. So a lot of times people look at the EKG and see a prolonged QT. As the potassium gets worse, you may see some ventricular ectopy. Severe hypokalemia can also produce some ST segment depression, and in fact, you can end up developing T-wave inversions, and that's what this is right there. That's a T-wave inversion followed by a giant U-wave. So the ST sags down, the T-wave sags down, is inverted, and then you get this giant U-wave, and what ends up happening in those mid-precordial leads is you have a biphasic T-wave abnormality. But the difference between this biphasic T wave and the true Wellens, and again, this is an EKG I've shown you before, with true Wellens, the critical LAD stenosis, what you'll see is that the T wave goes up and then down. And in this particular case, what you notice is that the T wave goes down and then it goes up. So sometimes I refer to this as a reverse Wellens wave. And in reality, this is actually a giant U wave, and this is an inverted T wave. So again, just taking a look at some of these leads, there's your inverted T wave and the gigantic U wave. So that's the T wave and the U wave right there. All right, let's look at a couple more examples. This is actually not uncommon at all. If you get patients that have severe hypokalemia, you'll see this. Pay attention to mid-precordial leads. You'll see the T wave go down and then up. That's an inverted T wave with a large upright U wave. Specifically, you'll oftentimes notice this in leads V2, V3, maybe out to V4. And if you don't know about this, you're going to mistakenly call this Wellens and maybe get cardiology involved, and it'll turn out to be severe hypokalemia. And again, this is another reason why a lot of times people start doubting whether Wellens actually exists, is because we have a tendency to overcall Wellens with some of these mimics. Here's another example of severe hypokalemia. Again, V2, V3, and a bit out there in V4. What do you notice? The T wave goes down and then it goes upright into a big U wave. And out here in V4, you see that sagging of the T wave that we talked about. Or sagging ST segment, then it goes up. So it kind of gives you this biphasic T wave appearance in V4, but especially prominent in V3 and in V2. There's your U wave, and that's actually an inverted T wave right there. And I'll give you one more example. This patient had Digoxin, and as you may recall, patients that have Digoxin can develop concurrent hypokalemia, and that's what this patient had. This patient had ditch toxicity with hypokalemia, and you know that there's hypokalemia because there's a biphasic appearance, V2, V3, and V4, but rather than a true Wellens appearance where the biphasic pattern goes up and then down, in this particular case, the biphasic pattern went down and then it went up. And when you see that biphasic pattern going down first and then up in those mid-precordial leads, and then especially if you notice kind of a longish QT interval in some of the other leads, you've got to really worry about severe hypokalemia. Now, the EKGs that just showed you, we're not talking about potassium levels of 3.3, 3.1, 3.0. We're talking about potassium levels of 2.5, 2.0, and in fact, let me go back for just a second. Well, this potassium level here in this EKG was around 2.0. Potassium level in this case that I showed you was around 2.2, as I recall. And if we go back to the original case, in this EKG, potassium level was about 1.8 or 1.9. The patient had some severe metabolic abnormalities going on. So again, we're not talking about mild hypokalemia, we're talking about dangerous hypokalemia. And for those international listeners out there who may use different units, normal potassium is 3.5 up to about 5 or 5.5 in the units that I'm talking about. So when I say that these potassium levels are 2 or 1.9, 1.8, we're talking about severe hypokalemia. So again, when you see the T wave go up and then down, think Wellens in those mid-precordial leads. But when you see the T wave go down and then up, think about severe hypokalemia. All right, so a simple case, a simple mimic to always remember. I hope that helped. Please don't overcall Wellens, and I'll talk to you next week. Bye for now.